I was anticipating, but it's certainly wonderful to have a full crowd. We will do our very best in terms of getting handouts to everybody, and I hope that the sight lines are okay. We could move into a bigger space, but then we wouldn't have the PowerPoint. So if anybody needs to do some last minute shifting around in order to be able to see the screen, the acoustics should be okay.
I can show.
Brian. Okay, well, I'm so pleased to present to you this evening our guest speaker, Dr. Brian Kerley. Dr. Kerley is a member of the Anglican Church of the Transfiguration here in town. He is a graduate from McMaster University in medicine and family medicine. He has been practicing medicine here in St. Catharines since 1983, and he has been in palliative care since 1988. And at that point, I need to look at my notes.
I thought that was excellent.
He is the lead physician and board chair of the Garden City Family Health Team. He is the medical director of Hospice Niagara, and he is an assistant clinical professor in the Department of Family Medicine and the Division of Palliative Care at McMaster University. And I'm going to turn the floor over to Dr. Brian Kerley. Thank you so much for being with us this evening.
Thanks for having me. Well, I have to say that's the second best introduction I've ever had. The best was one time when the introducer didn't show up and I had to introduce myself. So that's a really old joke too. So I'm happy to have been invited to talk about a difficult and controversial topic, one that evokes strong opinions from both sides of the argument, certainly a polarizing topic, a polarizing idea, certainly in some segments of society, less polarizing in society in general than you might think, and I'll talk about that in a few minutes. But certainly it's topical, and I think it behooves each of us to sort of think about these issues. And what Martha's asked me to focus on comes out of a dinner conversation that we had a couple of months ago, shortly after the Supreme Court released its decision on Carter v. Canada. And we were talking about the possible ramifications of that decision. And so Martha said, do you think you might be able to come talk to a small group of maybe 10 or 12 our weekly Bible study? Of course, I immediately said yes, and then it blossomed from there. Anyway, thanks for coming. I hope everybody can see the screen. Anyway, it is what it is. So I thought the topic is physician-assisted dying. I saw something floating around that said dying with dignity or death with dignity. I don't want to equate those two topics, so we can talk about that a little bit more later if you want to. In my mind, I don't necessarily equate those two things, so I'm going to go with what the Supreme Court of Canada has labeled physician-assisted dying. And I've subtitled it Practical and Ethical Issues because there are a number of both. The background is this, and these numbers are changing over time, but the background is basically this. In 2015, early 2015, 79% of Canadians support the idea of physician-assisted death. I'm not going to take a poll in this room, don't worry, I'm not going to do that. Good, but no, I don't. But 79% of Canadians, if you ask across the board, support the idea of physician-assisted death. So that is where we're starting from. But actually, if you ask physicians, 45% of physicians support physician-assisted death. And if you ask palliative care physicians, of which I am one, 27% support physician-assisted death. And if you ask that second group of physicians, the 45% who support physician-assisted death in the abstract, how many of them would participate if asked to do so in physician-assisted death? It's 27%. So you can see there's a bit of a disconnect between the general population's idea about physician-assisted death and the popularity of this as a concept in Canada and the kind of nitty-gritty, granular level at which somebody actually has to participate in doing this, where the enthusiasm for it is somewhat less. So you can look at this from two ways. Physicians are somewhat less disposed to participate in physician-assisted death, especially those that deal with dying patients in end-of-life care, palliative care physicians, many less than actually the Canadian population. But to flip that around and look at it from the other direction, if you are a proponent of physician-assisted death and think that that's something that you might want for yourself, there's only 27% of the population of physicians that are going to participate in doing that for you. So think about it from both of those perspectives. I want to talk about a few cases because it's all about people. So I want to talk about some people. And maybe this will sort of set a framework for you to think about the issues a little bit. And then we can have a bit of discussion if you want to later on, sort of free form. So I'll tell you about Margaret. Margaret is 84 years old and she lives in a nursing home. And she has advanced Alzheimer's disease and she cannot communicate. But she does sit up in a chair and the nursing home staff feed her with a spoon. And she seems to like that. When they put the spoon to her lips, she opens her mouth readily, allows the spoon to go in, takes the food off the spoon. She particularly likes desserts, but she readily accepts pureed food when it's offered to her. Occasionally she might close her mouth and the staff will take the spoon away and then they will try one more time and then she usually opens her mouth and accepts the food. Okay, so far? Not an uncommon scenario, elderly person in a nursing home with Alzheimer's. So Margaret's family asked you, I'm putting you in the role of director of care at the nursing home. Maybe you're a nurse, maybe you're a doctor, maybe you're an administrator. The family asked you to instruct your staff to stop feeding her altogether. Don't feed Margaret anymore. And they produce an advance directive written by Margaret 14 years ago that says the following. I, Margaret of Mission, BC, hereby declare that if the time occurs when I can no longer take part in decisions for my future, I wish this statement to stand as an expression of my wishes. If at such a time the situation should arise that there is no reasonable expectation of my recovery from extreme physical or mental disability, I direct that I be allowed to die and not be kept alive by artificial means or heroic measures. Okay, so far? Common sort of wording for a advanced directive, so-called living will. If the situation's hopeless, I'm not going to recover. I be allowed to die and not be kept alive by artificial means or heroic measures. So, are we okay? Okay? All right. I do ask that medication be mercifully administered to me to alleviate suffering, even though this may shorten my remaining life. Are we okay? Okay. This is called the principle of double effect. We'll talk about it a little bit more later on. I make this statement after careful consideration, and it is in accordance with my convictions and beliefs. I hereby absolve all who follow these instructions to be free of any legal liability. I'm sure about that. In particular, I would request the following instructions to be carried out. No electrical or mechanical resuscitation of my heart when it has stopped beating. Okay? No nourishment or liquids. Okay. No mechanical respiration when I am no longer able to sustain my own breathing. No surgery. In the event that mental deterioration is such that I'm unable to recognize the members of my family, I ask that I be euthanized. So we've got a little problem. Okay? So, and then she goes on to say, I hereby designate my husband John of Mission BC Canada to serve as my proxy for the purpose of making medical decisions on my behalf in the event that I become incompetent and unable to make such decisions for myself. Mark, if you haven't already thought about this, a session on like advanced directives and powers of attorney, it might be helpful for folks. I wasn't going to cover it tonight, but so it might be something you might want to think about doing at some point. It's a good topic for people to At the hospice, we're all about advanced care planning, and we're doing, I'll put in a plug for Hospice Niagara in a minute, and the dialogues, DIE-logs, that we're doing as a sort of public education thing about issues like advanced care planning. So anyway, more about that later. But it might be something worth talking about. So this is, she has designated her husband as a proxy for medical decision making, and if John's not able to carry out the wishes, then Kathy, the daughter, is appointed as an alternative proxy. So what are your and our obligations and responsibilities in this case? Here's this lady who has Alzheimer's disease, who readily accepts food when it's offered to her, and liquids, and the family are asking, armed with this advance directive, that you stop feeding her, and according to her wishes, and they haven't actually asked for euthanasia, but they have asked that you stop feeding her. So what are our obligations and responsibilities to Margaret? I present this also to our medical students and family medicine residents for their thoughts and discussions too. So I asked about what are their responsibilities to the patient, to Margaret, to her family, but there are other people we need to think about here, the nursing home staff who have to carry out these orders, and to the other residents of the nursing home. Because what we do for Margaret will set a precedent for others who are in the nursing home. Anybody want to throw out any thoughts or ideas about any of these topics, and then we'll tell you what really happened, and then we'll go on to some other interesting things. Yeah.
It's not fair to ask the nursing staff to starve someone to death. It's not going to happen. And Margaret is comfortable. And our first responsibility is to keep Margaret comfortable. By all means, don't keep her alive by artificial means, but starve her to death? No, not going to happen.
Okay. Yeah.
I actually have a very close friend whose mother was mentally competent, but so gone in all physical aspects, blind, etc. She chose to starve to death, and it was a horrible way to die. But she is allowed to refuse food if she's competent.
She is.
She did.
So what's
That
the,
one's not.
So what's the problem here?
She's not competent.
That's one.
Yeah.
And two, she's not refusing food.
Well, yeah, but as we know in that actual case, it's a physical response, just like a 3-month-old baby. She's not choosing to eat.
Maybe.
Touch her with her mouth open.
Maybe.
So, yeah.
Maybe. Yeah.
My mother had pulmonary fibrosis, which is a horrible disease.
Yes,
if
it is.
anybody's seen it. And she was really suffering. And we know the last 2 weeks that she was alive in the hospital, she refused to eat, she refused to drink. Now, as far as we're concerned, that was fine with us because it was her decision. She was still mentally competent and she was suffering terribly. And she was only going to live a little bit longer. So she literally starved herself to death, and she did it on her own.
Okay. So how does that relate to Margaret here?
Well, her family, somebody in my family could have come forward and said to the nurses and the doctors at the hospital, force her to eat, or put a feeding tube in it and make her eat.
Right. But they didn't. But thankfully they didn't.
Yeah.
Yeah. It's kind of the reverse situation here, isn't it?
Yeah.
Yeah. Where the family are asking for the opposite.
Yeah.
She seems to accept food, but they're saying stop feeding her. Yeah. And the other question is, how close to death is Margaret? Do you know? We don't know. Yeah.
It just seems unusual as an advance directive to say no food or drink.
Yep.
It's usually
Yep.
stated as no artificial,
Yeah.
you know, like,
Yeah.
and.
No nourishment or liquids.
Yeah, like that's, I've never seen it in that fashion.
Yeah.
And with that, I have seen no food, plans to keep it comfortable. 2015, 2012.
Okay. So the question would be, how enforceable is that advance directive? That really is what this case hinges on, isn't it? Yeah.
I think because it's the family that are saying no food, no drink, the onus is on them. The lady should be sent home to stay with them, and then they have to deal with that.
Yeah, not gonna happen. Not gonna happen. Sorry, nice try. Not gonna happen. Yeah.
Makes it different.
I think just one aspect that concerns me is that she made this advance directive 14 years before. And would that be considered? It would seem to me, does it make sense that this advance directive be renewed every so once in a while? I mean, what I thought about anything 14 years ago could be dramatically different now.
Could be, but however, it's the onus is on Margaret to renew the advance directive or review it or change it, the same as it is on our will. How many of us die with a will that says, you know, we're gonna leave everything to, you know, some group of people that we specified 20 years ago before those people died, left, when moved away, we have other things that we wanna do, so we're all guilty of that, aren't we? I mean,
If I was a family member though, I think that would weigh on my decision.
Yes, sir.
My wife was a victim of Alzheimer's, and I had a directive, there would be no artificial means of keeping her alive.
Yeah.
Her Alzheimer's condition caused her not to know how to eat. She couldn't process food.
Right.
She starved, but it took her months.
Yeah.
It was horrible to watch, but there was no alternative. This is the alternative.
Yes, it kind of is, because she's not quite in the situation of your wife, she readily accepts food.
Yeah.
But the family are asking that we stop.
Yeah.
All right, well, I don't want to get too hung up on this case because I got lots of other stuff and time is short. So what did the Supreme Court decide in February of 2014? They decided that spoon feeding is a form of personal care and not health care. And withdrawing oral nutrition and hydration for an adult that is not capable of making that decision would constitute neglect within the meaning of the adult guardianship. Because the difference is that health care could be withheld or withdrawn by way of an advance directive under the BC Healthcare Consent and Care Facility Admission Act, whereas basic personal care such as feeding, bathing, toileting cannot. And it is not something one could withdraw consent for in advance by means of an advance directive.
So is that her directive actually not legal?
Correct. That's what the Supreme Court ruled. The BC Supreme Court ruled that her advance directive was not enforceable, not valid, because she was attempting to withdraw consent in advance for basic personal care, and the court ruled that to do that would open up a huge can of worms and possibility for abuse, etc., etc. Okay, so that's Margaret. Now I want to talk
Does that get grandfathered over to other provinces as well?
I'm not sure that that's been tested, but it probably would. Probably would be referenced.
If she had a lawyer sign that, go through a lawyer, would it still not be?
Correct, it would not be. Now, I'm not sure that a lawyer drafted that document. It's got some aspects of legalese in it, but it's got some stuff in there that a lawyer would never put in, like I asked to be euthanized. Well, 14 years ago, you couldn't, and the question is, can you yet ask to be euthanized? So, let's go on, okay? Oh, by the way, just as a side note, that explanation was written by Hugh Scher for the Euthanasia Prevention Coalition, so just make note of that. Not the court decision, but the notes. Okay, I want to tell you about three people, real people. The stories that you are about to hear are true. The names have been changed to protect me, basically. So these are real people. Some of them are from a while ago, some of them are more recent. Ida, 69, and she's in hospice care, and she had breast cancer, which had spread to bone and brain. She's near the end of her life. She's not had any nutrition for 4 days. She's just totally unable to take anything in. She cannot swallow any longer. She's on injections of morphine for pain and some steroid, dexamethasone, to ease the swelling in her brain from where the cancer has spread to her brain. Okay, so far you can kind of picture this lady. So she has been very agitated and very restless for the last 48 hours, moaning, crying out, calling out. She's not able to respond to questions in any meaningful way. She's not able to respond to her family in any meaningful way. Her morphine was increased, but it really didn't help. She's had several doses of sedative, and that really didn't help either. With me so far? Okay. Her husband says to me, why won't you do something to end this? If this was Holland, we would have put her out of her misery by now. And then my favorite line, you wouldn't treat a dog like this.
You wouldn't.
Okay, hold that thought. Fred's 57, rapidly progressive thyroid cancer, thyroid gland right here in the neck. So Fred had this lump in his neck, and he went to his doctor, and they said, geez, I don't like the look of that. We better send you to an ear, nose, and throat consultant. But the thing was enlarging so rapidly that he never got to the ear, nose, and throat consultant. He wound up in the emergency room the following week with an obstruction of his upper airway. The thing was squeezing his airway, and he couldn't breathe. So he had to have an emergency tracheotomy, just down below where the thyroid is. So they put a tube in his trach so that he could actually breathe. So that was his start, and because the tumor was so aggressive and so infiltrative and around the arteries and the trachea and everything else, there was no way they could remove it. Way too far advanced. No possible surgical removal. So he had some radiation in Hamilton at what was the Henderson now, it's now the Juradinsky, and wished to return home to die because the tumor really didn't respond very well. Okay? So Fred's radiation oncologist thought that Fred was going to have a nasty end. He thought that the likelihood was he was either going to obstruct his airway, despite the tracheotomy, he might obstruct his airway and suffocate, or he might bleed to death if the tumor eroded into a large blood vessel. Both of those things can certainly happen. Very, very nasty. So the oncologist thought he should be in a palliative care unit where we could look after him, and that was my unit. So they called me. So I was the director of the palliative care unit, and I was contacted, and I agreed to take Fred's care over, and he was transferred late on a Friday night. Transfers from Hamilton always occur late on a Friday night. So I was out to dinner with my family and friends, and the pager went off. Get to the hospital right away. Fred's wife Mary is there. She is extremely upset and angry with the nursing staff. She's presented a note from Fred saying, please kill me now, I can't go on like this. So I came. And I arrived at the hospital, and she was distraught, and she was furious with me. I'd never met her. Furious. First time I met her, but she told me she was very upset because I had not agreed to give Fred a lethal injection tonight, as she was told that I would by the oncologist in Hamilton. Well, of course, the question is, what did the oncologist say? How did she interpret it, right? So I went and saw Fred, and he was alert, and he was oriented. He had his trach. He was communicating by writing notes, breathing normally, not short of breath. Said his pain was about 6 out of 10. So we do pain on a 0 to 10 scale. 0 is no pain, and 10 is the worst pain imaginable, right? So 6 out of 10, he's got a significant amount of pain, but we could probably deal with that, medications and things. He had a living will, which stated that he did not want any resuscitation. If my situation is hopeless, I don't want to have my life prolonged by artificial means. Perfectly fine. And then he wrote a note saying he wished to be given a lethal injection right now because he was suffering too much. Thoughts?
His wife's suffering.
His wife is suffering a lot.
Yeah.
That was a very good question, because one of our issues that we had to sort out, because of course we couldn't give him a lethal injection, right? But one of the issues that we really needed to sort out is who in the room is suffering. Actually, all of us were suffering, but she was. He was, but she was. And how much of his suffering was being taken up by her, and how much of hers was being taken up by him. And how much of both of theirs was being taken up by the nursing staff, who were as distraught as, and then there's me. So yeah, any other comments or thoughts before we go on to case number 3?
Do you think he really had a thought that you could give him a lethal injection?
He seemed to. Yeah, he seemed to. Both of them did. They absolutely expected that that's what we were going to do. And I don't know what was said in Hamilton. I'm pretty certain nobody said they're going to give you a lethal injection, but to them, transfer to a palliative care unit for end-of-life care meant that he was going to be doing it. That's how they interpret it. That's what they were expecting.
How long ago was this?
Mm,
And is he still alive?
15 years, 16
Oh,
years.
so he's no longer around.
Pardon me?
He's no longer around?
Maybe not that long ago. Let me see. Where were we? We were at the general hospital then. So maybe not, maybe 10 years.
It's interesting, he says his pain's only 6 out of 10,
Mhm.
then he's suffering too much.
Yes. So tell me more about that suffering.
Yeah.
So what are we talking about here?
Yes.
Yeah, we're talking about, well, there's an element of pain, of course. Sure, that's fine. But we can manage that usually. I won't say in 100% of cases, but in a large, vast majority of cases, we can manage pain. Breathing is not an issue, not short breath. So where was this suffering? Well, I think you're right. It's like what we in the biz call psycho-existential distress. The fear of dying and how that dying is going to take place, and the situation that he's in, and being stuck in the bed and can't speak. And
Maybe he didn't actually know what palliative care meant.
that's true. I think you're right. I think you're right. Well, certainly the expectations were. Yeah.
How close did you think he was to dying?
Not very.
And if you gave him painkillers, until he could still live some life and be free of low pain, would that be better than acceding to his request?
Well, that is the $64,000 question, isn't it? Because the position of the Canadian Hospice and Palliative Care Association and the Society of Palliative Care Physicians of Canada and the Canadian Medical Association is that we shouldn't even be having this discussion until we are able to provide excellent palliative care for everyone at the end of their life. But there's a problem with that, isn't there? We can't do that. There aren't the resources to do that. I'd like to stand before you and say, we're able to do this 100% of the time we can, but it's not true. It depends where you live, it depends who your doctor is, it depends on what part of Canada you're in, what part of Niagara you're in. You may have more or less access to palliative care.
Well, his request was to go home to die. There were issues about what type of death he would have.
Yeah, not home, but home to St. Catherine, not to his house. No, not to his house.
okay.
Well, you know what? Okay, I think that probably was an express wish, but I think the oncologist had convinced him quite rightly that it would have probably not been a smart idea. It would have been home would be a bad place to die of either suffocation or massive bleeding. All right, James, a recent case a month ago. James is 56. He's been a patient in the family practice of Dr. X for about 6 months. He was diagnosed by his former physician with fibromyalgia and chronic fatigue syndrome. Are we okay so far? We kind of have an idea what those are? Fibromyalgia is a kind of painful muscle and joint pain, discomfort. It's hard to pin down. There's no test you can do to prove it.
Same as diabetes with neuropathy.
Neuropathy, neuropathy of diabetes, the same kind of thing, but fibromyalgia is a bit different in that there's no underlying physical illness that you can put your finger on, but people have pain, okay? And then chronic fatigue syndrome, another poorly defined condition where people just feel extremely fatigued and tired, and you do a million tests, you can't find anything. Anyway, those were his things. His past medical history was otherwise unremarkable, no major illnesses. Dr. X felt that he was depressed after talking to him, but he denied being depressed, and he was unwilling to have a psychiatric consultation or to take antidepressants. Sometimes antidepressants help with pain in people with fibromyalgia. But he was not willing to speak to a psychiatrist or to take antidepressants. However, he was up on the news. And he heard about the recent Supreme Court of Canada decision about physician-assisted death, and he decided that he would like Dr. X to help him to die because his suffering is intolerable. Is it?
You haven't explored any other options?
Doesn't want to explore any of that. Wants to die. Wants Dr. X to help him to die.
He's depressed, that's his experience. You can't argue with somebody's experience.
Okay? So that's his experience.
But he's not incurable.
He's not even dying.
Isn't that part of
Let's except in the sense that we're all dying, right? On that some kind of trajectory. But he does not have a life-limiting illness.
And I guess the question is, if there is a concern about his mental health, the question of his ability to have actual consent and you know, an understanding of that may be diminished somewhat. I think that is taken into account.
So hold that thought, because that's important. Well, so those are three cases that come at the issue of physician-assisted death from three entirely different perspectives. Woman close to death, obviously suffering. Everybody standing at the bedside saying, oh my God, how much longer does this have to go on, including me. Meds, not helping. You wouldn't treat a dog like this. Why don't you, for God's sakes, do something and end this suffering? That's number one. Number two was not imminently dying, but certainly an illness that would take his life. And I would, in answer to your question, I would have guessed maybe a month. I don't know. But end my suffering now, I'm suffering. But what was the suffering? Was it physical, or was it psychological, or was it a combination of both? And three, not terminally ill, but I can't go on like this, my suffering is intolerable, help me to die. So I think we need to think about some of these kind of things as we frame the discussion. How do these three cases fit into the criteria outlined by the Supreme Court of Canada in its recent decision on Carter v. Canada? And we'll talk about that in a few minutes. Okay, time. How do we respond to these requests as things stand now? How may our response be different 12 months from now? But there are other things too, I think. We always, when we talk about ethics, we always talk about basic ethical principles that are applicable to medicine and to care, and they are beneficence, we want to help, non-maleficence, we don't want to do any harm, autonomy, the patient is in charge, and truth-telling, we don't lie to people about their illness. Gentle truth-telling, we tell people what's going on. We don't hide things and we don't lie. So we have to keep that in the back of our mind. Then there's the Marjorie Kerley principles, my mom, of treating everybody with kindness, dignity, and respect. Then there's pain and symptom management. Because no matter how we go, we need people's pain and other symptoms to be managed. People deserve to have pain controlled, and shortness of breath controlled, and nausea and vomiting controlled, etc., etc., etc. We need to relieve suffering to whatever extent we are allowed to do. We need to prepare people for dying. We need to be prepared, like in the case of the second gentleman, for suffocation or massive bleeding, because sometimes they happen. So that's on me, that's on us and my team to make sure that if that's going to happen, we're ready to act now and not start phoning, what should we do next? And generally our response to someone who begins to massively bleed or begins to suffocate is to sedate them to unconsciousness, and that's pretty, I don't think anybody would argue with that. It's a pretty well accepted principle in palliative care. If somebody's all of a sudden obstructs and can't breathe, or massive exsanguinating hemorrhage, we sedate them until they're unconscious, so they don't have to wait. But also we need to think about family dynamics. In many of these cases, there are always family issues that are playing into what's going on. We need support, and we need the support of the other members of our healthcare team, because we work together as a team on cases like these. We need to know what's legal and what is not. What can I do and what can't I do? We need to be clear on the difference between euthanasia and assisted suicide. What's different between that and good palliative care? Okay? Because there's a difference, at least right now there is a difference. And as Christians and as Anglicans, I don't trot this one up for the medical students, by the way. For this group, as Christians and as Anglicans, what is our perspective on all of this stuff? We need to consider that. The principle of double effect. Anybody familiar with the principle of double effect? If I threw that out, would you have some kind of an idea what I was talking about? Okay, I'll talk about it in a couple minutes with you then. And the question is, does it even apply? So the principle of double effect is this. This was born out of Catholic theology, St. Thomas Aquinas, and it had to do with the permissibility of using lethal force in self-defense. So in other words, if somebody's trying to kill me, it's permissible for me to kill them in self-defense. And that was how this was sort of framed by Thomas Aquinas. And what it says is this: in effect, it's permissible to indirectly cause an unwanted but foreseen consequence, a bad effect, if the primary intent of an action is to cause a good effect. So the way we trot this out usually in palliative care and in medicine is it's permissible to administer medication to relieve suffering, which is the good effect, even if that medication may shorten a person's life, which is the bad effect. It's foreseen, but it's considered acceptable if the primary intent is to relieve suffering. There's a couple of problems with this. There's more to it than that. Causing harm must not be so implicated as part of the means to the good end that it is instrumentally intended to bring about the good end. I.e. killing is a means to relieve suffering, but isn't that what we're here talking about? So this is going to break down. And there must be substantive independent justification for causing the harm. That's called proportionality. And I use so in other words, you have to consider the nature of the good end and the urgency in promoting it and the assessment of the harm involved. So I use the example of the medical students of the kidney stone. Sorry, Mrs. Smith, we had to relieve the pain from that kidney stone. Unfortunately, we gave him so much morphine that he died, but it's no, it's not acceptable. Okay, so proportionality. How compelling is it to relieve the suffering versus the potential harm that you might cause? And you have to exercise restraint and care in causing the harm, and you're only supposed to take this course of action when there are no less harmful alternatives. And you have to limit the production of harm to whatever is necessary to get to the good end. Once a person's suffering is relieved, you have to stop giving them morphine, or at least, not increase the dose, etc. So that is kind of the background on the principle of double effect. The problem with the principle of double effect is you can see it's going to be poked full of holes very shortly, right? Because of Carter v. Canada and other decisions. But the other thing about it is it often doesn't apply because there's really good studies that show that giving good palliative care to patients near the end of their life, good pain and symptom management, doesn't shorten their life. Relieving their pain and suffering doesn't shorten their life, it lengthens it. And there was an excellent study in the New England Journal of Medicine a couple of years ago where lung cancer patients were randomized to either excellent palliative care or usual care, whatever that was, and the ones in the palliative care stream lived 3 months longer. Yeah?
I volunteering at hospice in Guernsey. I only had a gentleman who had 6 weeks. He lasted 11 months.
Yeah. So,
They said they called
good
him an hour
good care. Good care. Yeah. So anyway, so let's just talk a little bit about the history of court decisions on this topic, and then we'll throw it open for whatever you guys want to talk about. Okay? So the first case that we have to talk about is Rodriguez v. British Columbia Attorney General, and that was 1993. That was Sue Rodriguez. Remember Sue Rodriguez? Sue had ALS, and she wanted to be offered physician-assisted suicide. So she petitioned the Supreme Court of British Columbia by the Attorney General. She petitioned the government of BC by the Attorney General. So Sue had ALS and petitioned the Supreme Court for the right to assisted suicide. As you know, she lost, right? But she did have assisted suicide. And Sven Robinson, the NDP member of provincial parliament, famously was there, and a physician who no one knows who that was administered it, and no charges were laid, and so on. But however, the decision was that she was not entitled. The court upheld 2 provisions in the Criminal Code of Canada, which had been upheld until a couple months ago. And they are that it is an offense to aid or abet a person to commit suicide. It's no longer an offense to commit suicide, you know that, right? Or to attempt suicide. It doesn't make much difference if you commit suicide, but if you attempt suicide, you can no longer be arrested and charged. It used to be, but not anymore. That's true. But it is still an offense to aid or abet a person to commit suicide. So you can't help somebody to do it. And the other thing is, no person can consent to their own death. You can't say, oh, kill me. You can't consent to that. Okay? And And so there was no defense in saying, well, I killed her, but they wanted me to. No, they are not allowed to consent to their own death. So those are the two basic principles in the Criminal Code of Canada that were upheld by the court in the case of Sue Rodriguez. It's an offense to aid a suicide, and she can't consent to her own death. So they said no. Now the next important thing that happened is in Quebec. So this is Bill 52, the Quebec legislation. And it's called an Act Respecting End-of-Life Care. And it was June of 2014. And the purpose of this act, enacted by the Quebec National Legislature, is to ensure that end-of-life patients are provided care that is respectful of their dignity and their autonomy. So that's the preface. And this act coined the term medical aid in dying. It's the first time that term, I think, had been used. So medical aid in dying means care consisting of the administration by a physician of medications or substances to end-of-life patients at the patient's request in order to relieve their suffering by hastening death. This is euthanasia, not physician-assisted suicide. Do you understand the difference, right? Physician-assisted suicide, I prescribe you a whole bunch of drugs and you take them. Euthanasia, I give you the drugs. I administer them to you. That's the difference. Morally, ethically, probably not a whole heck of a lot of difference, really. I suppose you could argue, oh, I gave them the prescription and I didn't really know what they were going to do with me. No, come on. Not true. Not true. When you give people massive doses of barbiturates and things like that, you know the intent is there. So, anyway, be that as it may, in Quebec, it is administering a substance by a physician. So, in order to qualify for this, only a person who meets all of the following criteria can obtain medical aid in dying. They have to be insured, because nobody can get anything unless they have health care insurance. They have to be of full age and capable of giving consent to care. Not sure what full age is, but they have to be capable of giving consent. Capable of giving consent. Okay? They have to be at the end of their life. Okay? Thinking about the cases that we talked about. Okay. They have to suffer from a serious and incurable illness. They have to be in an advanced state of irreversible decline in capability, and they have to experience constant and unbearable physical or psychological suffering, which cannot be relieved in a manner the patient deems tolerable. I don't care about those antidepressants. I don't want counseling. It's not tolerable. The patient must request medical aid in dying themselves in a free and informed manner by means of a form. They've got a form for this. It's government job. Right? Prescribed by the minister. And the form has to be dated and signed by the patient. Oops. And then the form has to be signed in the presence of and countersigned by a health or social service professional. And if the professional is not the attending physician, then the signed form is given to the attending. Maybe a social worker co-signs it, gives it to the attending physician. And then what happens? The physician has to obtain the opinion of a second physician. Ooh, that is one. The physician, that is the consultant, the second physician, has to be independent of both the patient requesting medical aid in dying and the physician seeking the second opinion. The consulting physician has to consult the patient's record, examine the patient, and provide an opinion in writing. So the patient has to request it on a form. They have to be competent to request it. All those other criteria have to be met. The form is given to their attending doctor. The attending doctor has to get a second doctor to review the case, see the patient, review the chart, write a decision.
Is this 2 years?
No. It has to take place in a timely fashion. A patient may at any time and by any means withdraw their request for medical aid in dying. And a person of full age who is capable of giving consent to care may, by means of advanced medical directives, specify whether or not they consent to care that may be required by their state of health in the event they become incapable of giving consent. However, in such directives, the person may not request medical aid in dying. So you can't ask for this in an advanced directive or a living will or a proxy. You cannot request medical aid or physician aid to die in advance, in an advance directive. They were looking at the BC case, right, when they drafted that. Then, so that was passed in July of 2014, but it's suspended for 18 months, takes effect in 18 months. So hospices and hospitals and other organizations and care settings and nursing homes and so on have 18 months to get their policies and procedures in order to decide what they're going to do, et cetera, et cetera. And by the way, no physician and no hospice or other institution can be compelled to offer this in Quebec. You don't have to offer it. But like a lot of things in medicine, if you don't offer it, you have to tell the minister why in terms of a form, and you have to facilitate somebody else getting involved that will offer it if the patient requests it. Now Carter v. Canada. So this is the most recent one, right? This is the one that draws us all here tonight. So Gloria Taylor was 61 years old, also in British Columbia, and she was diagnosed with ALS, and she desired to end her own life at a time of her own choosing. Okay? That was Gloria. And Kay Carter, who was 89, was suffering from spinal stenosis, which is a really painful condition of the spine where spinal cord is kind of being squeezed by a lot of arthritis, and it makes it really difficult to walk and very painful. And she was confined to a wheelchair, and she went to Switzerland in 2010 for physician-assisted death. She was not terminally ill, but she had a really painful spinal condition. So the British Columbia Civil Liberties Association decided to file suit on behalf of these two plaintiffs, challenging the Criminal Code of Canada's prohibition on assisting suicide. Those two things that we looked at with Rodriguez, right? You can't consent to your own death, and nobody is allowed to counsel or abet in a suicide. So BCCLA decided to challenge those criminal code prohibitions on behalf of Carter and of Taylor, Gloria Taylor. So the case was heard at the Supreme Court of BC, who ruled in favor of the British Columbia Civil Liberties Association in June of 2012, and suspended the ruling for a year and said, get your ducks in order. Gloria, you can have physician-assisted suicide, but nobody else can. We want the Supreme Court of Canada to review this, and then in a year's time, presumably it'll be law. But unfortunately, or fortunately, I don't know, depending on which side of the fence, she said the government of Canada didn't like that, and they appealed the ruling to the Court of Appeal of BC, who overturned it in October of 2013, so now it's not allowed. But not to be deterred, the BCCLA then filed a leave to appeal to the Supreme Court of Canada, and that's what we're here talking about today. So in February of 2015, the Supreme Court of Canada struck down the provisions in the criminal code that prohibit assisted suicide. So it is no longer an offense to aid or abet or counsel suicide. And you can now consent to your own death, because those provisions in the criminal code have been struck down. Well, this is a bit like the abortion situation, isn't it? The prostitution situation, excuse me, not the abortion situation, the prostitution situation, where the laws prohibiting it have been struck down, but we don't have any new laws saying what's possible and what's not possible. So we've struck down the prohibition against assisted suicide, and now it's wide open. So the Supreme Court decided, and this is interesting, that by not allowing suffering patients to end their lives with the help of others at the time of their choosing, that the current law violated their constitutional rights in the Charter of Rights and Freedoms. The current law effectively forces very ill patients to take their own lives prematurely, rather than risk being incapable of doing so when their suffering actually becomes intolerable. So this is using a right to life argument to support the right to death. I have to kill myself now while I'm still capable, because you won't allow a doctor to do it for me 5 years from now when I won't be capable. So therefore I have to do it now, so you're robbing me of 5 years of life. That's the argument. That's the argument that the court used. So it violates the constitutional rights of the patient by making them have to take their own life prematurely if that's what they want, rather than allowing a doctor to do it later on when they're not capable.
You're using the word capable to mean physically capable.
Physically capable, yes, not mentally capable, no, that's a different issue,
No,
yeah.
I know.
Physically capable of doing it, because ALS, Gloria Taylor, ALS, and many of these requests are ALS patients, because they will lose the ability, lose muscle ability, right? They maintain mental faculties, but they lose the ability to use their muscles, so they cannot physically kill themselves any longer. So, I'm gonna have to kill myself now, before I get too sick, because you won't let a doctor do it for me in 5 years. So you're robbing me of 5 years of life. That's the argument. So it also said that the current law denies dying people the right to make decisions concerning their own medical care unless it violates the Charter of Rights. It wasn't fair, the court decided, that patients can request pain relief and sedation, refuse nutrition, or request to remove life support equipment, but we're not allowed to request a doctor's assistance to die. The court was very specific in its wording, and it noted that the patient should be a competent adult, that's mentally competent, okay? They have to be competent, and they have to clearly consent to end their life, and they have to have a grievous and irremediable medical condition. What does that mean? Don't know. This could include a disease, but it also could include a disability that causes enduring suffering and that is intolerable to the individual. Note that the individual does not need to have a life-threatening illness or condition. Just suffering.
So Brian, for consenting that they have to be mentally capable of making these decisions, who deems that they're competent?
Don't know. So the court suspended this ruling for 12 months. In other words, it said, this is our ruling, but nothing's going to happen for another year. We've ruled this, but current law holds for 12 more months. So it's going to take effect in 2016. And that was done in order to allow Parliament to craft legislation. And what has Parliament's response been? Hi. So, Government of Canada, so anyway, by the way, just as a side note, in its current form, this ruling is the most permissive in the world. No other jurisdiction in the world has a ruling this wide open. You only have to be capable, you don't have to be terminally ill, you only have to be suffering. And it can be physical or psychological or whatever.
So that man way back, that one, that had fibromyalgia.
He's a candidate.
But he was well enough that he could have done it himself.
No, but why would he have to? He can ask a doctor to do it.
Then he takes the only doctor.
But that doesn't allow for somebody who, say, just gets diagnosed with Alzheimer's or dementia, and knows that down the road, they're gonna be in a situation where they might want it, but they won't be deemed able to make that own.
We don't know whether this can be assigned by proxy because that's not stated in the decision. We don't know whether you can specify in advance that if your condition becomes, we don't know whether Margaret Bentley's living will is now valid.